So around 3.5 years ago I started working in the prisons, and I very quickly realised how many prisoners were smoking, probably on average around 90%, and that there was not any screening programme in place for picking up COPD, and there was not any long-term condition health promotion or clinics running. So I realised that this was an inequality in health, and obviously they should be receiving the same care as they would out in the community, so that something needed to be in place to address that. So I applied for a job at Maidstone Prison, which was mainly elderly offenders, and in my interview I discussed that this, from previous experience in prisons, this is what I've seen regarding the amount of smokers and lack of screening, and my vision would be to set up pulmonary rehab, which was a passion of mine from being a student and on a respiratory placement. So I was given the go-ahead as long as I could find the resources to set this up without using money. So I contacted the COPD team within Oxley's, and then I ended up meeting Helen Jefford on a mandatory training day and discussed our visions, and obviously this was Helen's everyday work.
So pulmonary rehabilitation is a course specifically designed for people with chronic lung disease. It involves an exercise component which is designed to help patients feel better, stronger and fitter, and also an education component which involves giving patients the tools and the knowledge to be able to help them self-manage their condition.
The project first came about, I think, at a routine meeting that I was attending at Maidstone Prison, which was just a regular meeting. I was talking with staff there, including Nina, and she had recently met Helen Jefford at a trust induction, and so it kind of happened in some respects by accident. Nina had been particularly interested in respiratory care, and as a student that was her point of focus for her final dissertation. Her trust induction, she sat next to Helen Jefford, who is a physiotherapist within the trust, and was running a pulmonary rehabilitation programme, and the two of them just began to talk, as I understand it, and Nina was talking about the healthcare needs of the prisoner population in Maidstone, which was quite an ageing population, lots of respiratory issues, smoking being very prevalent in the prisoner population, and clearly a concern that there was an unmet need in terms of COPD and pulmonary rehab. And I think together the two of them thought, well, we may be able to do something with this. So it was raised at the meeting with me, is this something that we thought we could support? And I was really, really excited about it, I think, for a couple of reasons. One, I've worked in prisons for many, many years in the role that I'm in, and have seen healthcare often being very limited in terms of what's available to prisoners, and it felt like this is something that is there and available to people in the community, and yet in a prison setting it's just not there. I recognise that there are lots of prisoners that end up going out to hospitals, and managing their healthcare needs is particularly difficult, and there are economies and efficiencies by trying to look after people within the prison if at all possible. So I was very keen to support it for a number of reasons, and kind of moved on from there. Some of the issues that I thought might be problematic, because they often are, was partnerships, and I recognise that for this to happen in the way that Nina and then later Helen described, we would need to have a close working relationship with the prisoners, and I needed to know that the governor and the security governors were on board with this, because it would push boundaries in a way that isn't easily achieved in a prison setting.
I mean, I was at Maidstone prison for over 2 years, and during that period it seemed that the age demographic was increasing, and that was having an impact on the kind of conditions that, from a health perspective, that we were having to deal with, particularly age-related illnesses and ailments, but also it seemed to be a heightened case of prisoners who smoked and the impact of smoking. I think it'd be fair to say that there are more people that smoke within prisons as opposed to outside of prisons, and the damaging effects that can have could arguably be greater because of they tend to smoke in confined spaces because there are restrictions in terms of where someone can smoke. And so all of those things together, when this project kind of was first suggested, seemed to make sense purely from the health perspective.
It was really pleasing to hear that very early on that support was there, and it didn't take much to provide some background to the project and for all parties to see the relevance and the benefits of it. So we were quickly able to engage the physical instructors within the prison. I think they saw it as a great opportunity for them. We were able to get the support from security and other parties so that if equipment needed to come into the prison, then that was facilitated. And all the way through there was a sense of, well, this is a great project for Maidstone Prison, and it was pushing boundaries, and clearly if we can take this out more broadly, that would be fantastic. The other things around that I think that were important was, as a trust, Oxley's sees itself very much as an innovator, and I think from my own trust perspective, we are looking for opportunities to explore new grounds, whether that be in a prison setting or whether that be in our mental health or community services, and this certainly hit those particular buttons.
So what we've identified is a huge unmet need for the prison population diagnosed with chronic lung disease. This population have no access to a pulmonary rehab programme, which they would have perhaps accessed in the community if they were diagnosed. So this obviously poses a huge problem for us in terms of equality across the community and the prison population.
Helen came down to Maidstone Prison and looked around, and we luckily had the resources already in place, which was the gym. We had fitness instructors that also had realised that they were struggling how to manage elderly offenders within the prison setting using the equipment and with breathing difficulties. We managed to get free training for spirometry for myself, and then Helen was given the time through Oxys and meetings, and we discussed how this could work, and potentially from the amount of admissions we had going out to A&E at that time with people with COPD from exacerbations or purely officers, because our service only covered till 6:30. So through the night, if an officer was to go to a cell and see a prisoner was not breathing well, however it was COPD, and they didn't realise that was the problem, and the patient would panic because they didn't know any better, would call an ambulance and they would go out to hospital. So our vision there was to hopefully educate officers as well and prevent admissions to outside hospital. So we set the service, we started to do the screening. That was the initial, and Helen came to mentor me, and we quickly realised how little education the prisoners had had. Through some of them had been in prison for over 12 years and never had been educated about their condition or had any resources to find out about COPD, and probably the most information they'd been given is an A&E visit to find out what was wrong and come straight back to prison. So we had a lot of work there to educate people in the first place and overcome the barriers of them wondering what we was doing.
So the prison healthcare nurse and myself decided to identify the appropriate patients by screening all those prisoners who were over the age of 35 and smokers. We identified 276 patients that needed screening. Out of these 276 patients that were screened, we identified 38 patients who were perhaps appropriate to be assessed for the course of pulmonary rehab. We then identified a further 22 patients who are appropriate to attend our pilot project of running PR in a prison. So it's important that we were able to replicate the current pulmonary rehab programme which we were running out in the community, and whether we could transfer that programme within the prison setting successfully, safely and effectively. It's really important that we were able to support those patients who were diagnosed with a chronic lung condition, and even more importantly screen those smokers over the age of 35 who have perhaps not got the correct diagnosis. So it was important that we invited appropriate patients to attend the pulmonary rehab course, and those were those that have been diagnosed with either moderate, severe or very severe lung disease, and these often are the ones that are most affected by their breathlessness. But it was also to help identify those that perhaps who were more physically able, but actually were more socially isolated and needed support in terms of understanding about their lung condition and empowering them to be able to do more. So when selecting the patients to attend the group, it's also really important to consider other aspects in terms of ensuring that we were running the programme safely for the prisoners and the staff themselves. I was very much guided by the prison healthcare nurse in terms of how the runnings of the prison works in terms from a safety aspect, but we needed to make sure that we were inviting the right type of patient. Could our patients, were they happy to be in a group setting? Were they happy to be in a group setting with other individuals on the prison wings themselves? So it's all these things that you had to take into consideration to make sure that the class runs completely safely. So we assessed physical exercise performance by performing the 6-minute walk test pre and post pulmonary rehab, which gave us an indication of how much fitter they were. We also asked the patients to fill in several questionnaires. These included a health status tool. This was a CCQ, which is the clinical COPD questionnaire, and this gave us an idea of how it impacted on their quality of life. We also asked them to fill in 2 questionnaires. One was called GAD-7, the other PHQ-9, and these 2 in turn looked at their mood, and specifically their anxiety and depression levels pre and post pulmonary rehab.
So we had to liaise with the prison governor and the gym as well to make sure we fit the course around the prison regime, which was important that they had to change a lot of classes around, which was brilliant that they did that for the course. We did it as you would outside. We did twice a week, so we did it on Tuesday and a Thursday morning for 2 hours, and that was for 7 weeks. So we did 2 courses, so overall there was 28 classes that we ran.
So we were very lucky. We were very well supported by other members of the team within the prison itself. So we had contributions from a dietitian, mental health care nurse, the GPs, and also the smoking cessation team. So their involvement was they would come along to the education part of the programme and discuss all the relevant things in terms of their expertise, and this in turn helped patients to gain the knowledge and the skills that they needed to continue to look after themselves when they're alone in their cells. We also used the CAT tool, which again is a COPD assessment tool, which gave us really valuable information pre and post pulmonary rehab. And we also wanted to look at their knowledge gains. So for this we used something called the Bristol COPD Knowledge Questionnaire, which is a series of 65 questions, and it really helps us to understand what the patients know about their lung disease, and then obviously what they've learned as a result of attending all the education sessions. Patients normally get referred to pulmonary rehab by talking to their practice nurse or their GP and asking to be referred into their local respiratory team. So what we were able to establish within the prison setting is that we found a group of patients where smoking instances were high, social isolation was a huge problem with high levels of anxiety and depression, and these patients were often experiencing very sedentary lifestyles, which has a massive impact on their ability to be able to cope with their chronic lung disease. Research tells us that pulmonary rehab is a really effective way of increasing patients' fitness levels and their exercise capacity by attending this group. It's also been shown to demonstrate lots of other improvements such as quality of life. It can reduce anxiety and depression levels, and it also helps patients to feel much more supported when it comes to living with their long-term lung condition.
I became anxious a little bit, not majorly so, but there was a level of anxiety that, we could do a great piece of work here, but there wouldn't be an evidence base to support it. And I'd previously worked quite closely with Canterbury Christ Church University and other projects, and already had an existing relationship with key personnel there. And I thought that early on it would be helpful also to engage Canterbury Christchurch around supporting the development of an evidence base to the project, which I think then gave it kind of gravitas and real support. So I did meet with a professor there and explored the opportunity of engaging some staff from Christchurch, and it was great then that Sonia and Julie came on board and have been part of the project team.
In terms of the qualitative findings from the project, it's well documented that pulmonary rehab benefits participants, whether as inpatients or outpatients. What we didn't know was whether our participants would report meaningful improvements to their quality of life in this particular setting.
So we administered the data collection instruments pre and post the Pulmonary Rehabilitation programme, and then we used paired t-tests, and the purpose of that was to look to see whether there was a significant difference between and after the Pulmonary Rehabilitation programme.
Encouragingly, some of our participants reported being able to manage their symptoms more effectively when they occurred in their cell, particularly when they'd experienced frightening episodes of breathlessness during the night. They just had more confidence in dealing with this.
So we found improved scores on all 6 of the outcomes. 3 of these were statistically significant at the 5% level. This was the 6-minute walk test, the CCQ, and the COPD knowledge questionnaire, which is the BCKQ.
Improvements were also recorded via the clinical COPD questionnaire, in particular that the burden of COPD within the prison setting was reduced.
Although levels of depression and anxiety were improved, these weren't statistically significant, and that wasn't really surprising to us based on the population we were working with, because I expect there was lots of different variables that would impact on scores of depression and anxiety in a prison setting.
Specifically, participants also reported a greater understanding of their condition and how to manage their symptoms when they occurred.
Although this was a small sample, the results are really encouraging to us and suggest that a programme such as this could be rolled out across other prisons with similar positive benefits.
The impact of general overall improvements to their physical condition gave the participants confidence to do more within the prison itself. These results really reflect the importance of selecting the right type of participant to take part in this programme within this type of setting.
From what I understand, an impact kind of really from a number of levels. I mean, from the individual prisoner's perspective, understanding actually the benefits to them in some of the kind of things that they learned in terms of how they can manage their own health, some of the exercises they could do in cell that would help them feel better and stronger, and an understanding then that they were actually able to do more physical things than maybe they thought they were, because they were able to manage the condition better. I think an awareness amongst staff that actually equally that actually there are a number of prisoners actually could do more in the gym than maybe previously we thought, because they were learning how to manage the condition in order to be able to kind of engage more in activities. I understand there was one example of somebody who previously always took his nebulizer with him when he went to exercise, but actually stopped doing that because he understood that it was actually okay to be out of breath. And sometimes, you know, there are some benefits in doing some exercise that actually will get you out of breath and kind of recovering from that. So I think a greater understanding in terms of the ability of individuals to be able to engage in exercise, which again will improve the health, but also an understanding from staff as they became more aware about the kind of conditions that people were kind of suffering from, that there are some prisoners who will have reasonable cause for not being able to work as hard as some other people, and if you understand that actually that's because of a health issue, not just because they're being lazy, we do have some of that in prisons, then you know that there was the kind of benefits there as well. So the greater understanding generally across the prison.
The outcome, I think, of the project has far exceeded my kind of initial thoughts. You know, I always thought it would be a great project, but the outcomes in terms of the benefits to the prisoners are clearly there for us to see in terms of the limited, it has to be said, limited numbers that we've got, but the benefits and the feedback that we've got from those prisoners that have been involved have been magnificent, and There are lots and lots of examples of that where prisoners have made statements to Nina and to Helen, and when you look at the clear benefits of the various kind of measurements, it's again there to see, and it's been recognised at a national level. So the Nursing Times has recognised Nina in terms of the work that she's done around respiratory care, and that felt like Nina was there as a figurehead for the whole of the project team, and so it was nice for us all to go up and see that award being made. So I'd like to think that the project can be used now in other areas, in other prisons. Certainly where we manage prison healthcare, we are looking for opportunities such as this, but I think that there's many other prisons around the country that today will have a similar demographic to that of Maidstone Prison in 2012-2013, that a project like this could be hugely beneficial to those prisoners.
The more people I have to send out, the more of an impact that's likely to have on the day-to-day running of the prison. And whilst we want to provide equitable health services, it was always going to present us with some challenges. So if we can kind of run this kind of project that will reduce the need to send people out, the benefits are kind of significant from an operational perspective, and also from a security perspective, depending on the type of prison that this kind of work is going on in. Every time we send someone out, there's a security risk. Obviously, there's the impact on the day-to-day running of the prison, but from a kind of cost perspective, from the NHS's perspective, who have to fund those escorts and obviously all of the appointments out in the kind of local community, there's a significant reduction in cost from an NHS perspective, and ultimately from the public purse. So from the taxpayer's perspective, there has to be a benefit in this kind of approach.
So what we've identified is that the prison healthcare teams are going to need support from a variety of people, upmost the governor of the prison, but also local community respiratory teams, the trust itself, and also the nurse who is perhaps driving forward the pulmonary rehab within a prison setting. She'll need support in terms of any training needs. This might be with training with spirometry, helping to get patients diagnosed correctly, and also help the delivery of the programme itself.
For healthcare in the prison settings, now this has really put the spotlight on what we're doing, and it's really, everyone seems really excited and interested, and for the one thing, I'm hoping that it will improve recruitment for nurses, seeing that this actually is a really interesting, challenging environment to work in.
It's absolutely crucial that our project of providing pulmonary rehab in a prison setting doesn't stop here, and it's the prison healthcare teams that need to champion this piece of work that we've done, and by pulling in all the available resources to make sure that prisoners continue to receive specialist care such as pulmonary rehab.
Having moved on from Maidstone Prison, I've now been at Rochester Prison for almost 3 years now, and we've been experiencing exactly the same issues actually in terms of the numbers of prisoners that we're trying to get out to external healthcare appointments and the impact that has on the regime. So, I mean, this is clearly something that I'll be looking at in terms of promoting and embedding into the health provision in Rochester, both from a reduction in terms of external escorts, as I said previously, but also to improve the health, because whilst I have a whole range now, an age range from 18 all the way up to, I think the eldest prisoner is in his 70s, we will still be having prisoners with similar needs as was experienced when this project took place in Maidstone.
Inequalities in prison health, this is just the beginnings. I think COPD was just one area that needed addressing. Every prisoner is entitled to the same care as they would receive outside, so hopefully people across the country in prisons and nurses will start picking up on the work we've done, and obviously with all the promotion that we've had with it, which has been brilliant, it's spread the word for people to start changing prison healthcare, especially with the governors on board, because not only is it they're entitled to that healthcare, it also saves money within the prison setting, safety, and For me now, I'm working as a manager in Rochester Prison, and our aim is to again set up pulmonary rehab, but not only that, to address each long-term condition, and everyone have a speciality and decide what they need to do to make sure that's on par with what someone would receive out in the community.
I think it's also really important to highlight the fact that this whole project couldn't have happened if it wasn't for the integration of so many teams working together, not only external agencies but also within the prison itself, and most importantly the fitness instructors who are working with these prisoners and our patients once they've completed pulmonary rehab on a daily basis. And they're also really important because they have that social contact with prisoners and our ex-patients. And they're there supporting them for when they have graduated from our class.
As a prison nurse, you do know that you chose to work there, and you're not there to punish them. You choose to work there, and you should be offering exactly the same as what they receive outside.